For our new viewers and also our returning members, you are welcome to Smart DX Media, where public health, education, information, and our general well-being is extensively considered very important. Today we shall be talking about protozoan parasitic disease condition Leishmaniasis, is a disease caused by protozoan parasites of the genus Leishmania and spread by the bite of certain types of sandflies called phlebotomine. It represents a complex form of diseases with identical clinical and epidemiological diversity. Depending on their clinical symptoms, there are three main forms of Leishmaniasis: visceral, also known as kala-azar, which is and the most serious form of the disease; cutaneous, the most common; and mucocutaneous. Kindly watch, subscribe, share, and hit the notification bell icon, especially for our new viewers or our returning viewers who are yet to subscribe, so that each time we release new health tips or videos, you should be notified as well. Leishmaniasis is caused by protozoan parasites, which are transmitted by the bite of infected female phlebotomine sandflies. The disease affects some of the poorest people and is associated with malnutrition, population displacement, poor housing, a weak immune system, and lack of financial resources. Leishmaniasis is also linked to environmental changes such as deforestation, building of dams, irrigation schemes, and urbanization. An estimated 700,000 to 1 million new cases occur annually. Only a small fraction of those infected by parasites causing Leishmaniasis will eventually develop the disease. It's not very healthy, to say the least. At Smart DX Media, we're counting down our picks for the top terrible things Leishmaniasis does to your body. Before we begin, we publish new content every day, so be sure to subscribe to our channel and ring the bell to get notified about our latest videos for this list. We're looking at the most harmful and dangerous effects that Leishmaniasis has on the human body. Epidemiology: Leishmaniasis is a neglected tropical disease infecting the world's poorest populations in over 90 countries throughout Asia, Africa, the Middle East, and Central and South America. While likely underreported, current estimates of cutaneous Leishmaniasis incidence range from 700,000 to 1.2 million cases per year, with approximately 95% of cases occurring in the Americas, the Mediterranean Basin, the Middle East, and Central Asia. Estimates of annual visceral Leishmaniasis, VL, are currently less than 100,000, which is a significant decrease from prior estimates of 400,000, with more than 95% of cases reported to the World Health Organization, WHO, from Brazil, China, Ethiopia, India, Kenya, Nepal, Somalia, and Sudan. Risk factors for Leishmaniasis include poverty, population migration, malnutrition, poor hygiene, and an immunocompromised state. The sandflies are found across the globe, and tropical species can complete the life cycle throughout the year. In subtropical areas, however, species can only complete their life cycles during warmer months. Most active at night, the sandflies fly silently and are often not heard or seen by their prey. There are 22 species belonging to the genus Leishmania that has been further subdivided into the subgenera Leishmania and Viania based on development of the organism in the digestive tract of the sandfly. Each parasite species has specific geographical predilections, host factors, and symptom characteristics. Kindly watch, subscribe, share, and hit the notification bell icon, especially for our new viewers or our returning viewers who are yet to subscribe, so that each time we release new health tips or videos, you should be notified as well. For example, L. Donavoni presents as VL in South Asia, Bangladesh, India, Nepal, and East Africa, Sudan, Somalia, Ethiopia, and Kenya, and often predominates among younger individuals while sparing older adults due to acquired immunity. L. infantum, same species as L. chagassi in Latin America, on the other hand, also can present as VL, but is usually found in the Mediterranean, Middle East, Pakistan, Iran, and Brazil. In Texas, all endemic cases of Leishmaniasis were found to be caused by L. mexicana CL life cycle. The female phlebotomine sandfly, mostly active in the nighttime hours, from dusk till dawn, transmits the Leishmaniasis parasite to humans or other animal reservoirs. Leishmania spardii has two distinct phases in its life cycle: promastigote and amastigote. The promastigote form has a flagellum allowing mobility in the sandfly's intestines. When the sandfly takes a blood meal from the mammalian host, The promastogote form is injected into the skin and is phagocytosed by mononuclear cells of the mammalian host, transforming it into the amastogote form, also known as Leishman-Donovan body. The amastogotes multiply and develop within the reticuloendothelial system of the host, causing either the asymptomatic or symptomatic forms of the disease based on underlying host and parasite species factors. The amastogotes can travel hematogenously and lymphatically to cause mucosal and visceral disease. Recently, researchers have discovered that the Leishmania RNA virus, LRV1, co-infects L. viania v. guyanensis and L. v. brasiliensis species, eliciting a hyperimmune response through toll-like receptors causing mucosal damage and metastatic infection. LRV outside of the Viania subspecies was discovered in L. major, categorized as LRV2, but no association between clinical phenotype and severity has been elicited. At Smart DX Media, we're counting down our picks for the top morbidity or mortality of Leishmaniasis does to your body before we begin to publish new content periodically. So be sure to subscribe to our channel and ring the bell to get notified about our latest videos. Transmission. The transmission of Leishmania sp is predominantly driven by symptomatic infection and post-kala-azar dermal leishmaniasis, PKDL, as asymptomatic cases are thought to not infect sandflies. In some areas, humans are required to maintain the life cycle, anthroponotransmission, which is characteristic of L. tropica, responsible for CL in the New World, and L. donovani, responsible for VL in India. Animals, however, can maintain the life cycle and may or may not exhibit signs or symptoms of disease. Dogs, rodents, marsupials, monkeys, and edentates are among the susceptible hosts. In particular, dogs are the most important animal reservoir for L. infantum bursa S. Less commonly, Leishmaniasis can also be transmitted through organ transplantation, blood transfusion, intravenous drug use, or congenitally. Pathogenesis. Leishmaniasis is classically thought of as an imbalance of Th1 versus Th2 CD4+ helper cells. Those with a primary Th1 response have excellent parasite control with low levels of parasitemia. However, they are primed toward mucocutaneous disease as a result of overactive cellular immunity and cellular destruction. Those with a Th2 response have increased parasite load as antibody neutralization is ineffective against the intracellular parasite. Th2 responders are more likely to develop disseminated disease, which leads to visceral disease and, in the New World, results in disseminated cutaneous leishmaniasis, DCL. Clinical symptoms. While leishmaniasis can present with a variety of different clinical manifestations, the main three phenotypic categories of disease are cutaneous, mucosal, and visceral leishmaniasis. These categories can be subdivided further to encompass the spectrum of clinical disease to include ML of the Americas, VL, CL of the New World, CL of the Old World, post-kala-azar CL, Leishmania recidivante, diffuse CL, and disseminated CL. Moreover, the appearance of cutaneous disease can be variable. In some individuals, infection can remain asymptomatic or subclinical, but it can also present as acute, subacute, or as a chronic disease. Diagnosis. The diagnosis of leishmaniasis is often challenging, but can be made clinically with direct, parasitic, and indirect immunologic confirmation. Confirmation of diagnosis is often not practical in low-resource countries. The history, epidemiology, clinical symptoms, and signs on physical examination should alert the clinician of the possible diagnosis of leishmaniasis. In particular, a painless, non-purulent skin ulcer on the face or extremities in a person with recent travel to or migration from an endemic area should prompt concern for cutaneous leishmaniasis. Alternatively, prolonged fevers, fatigue, weight loss, anemia, leukopenia, and hepatosplenomegaly in a patient from an endemic region such as Africa may suggest visceral leishmaniasis, in addition to HIV, TB, and malignancy. Given that treatment can be toxic and differs substantially based on species identification, clinical diagnosis of leishmaniasis is not sufficient and should ideally be confirmed by evidence of amastogotes in tissue and/or molecular testing, such as polymerase chain reaction. Kindly watch to end, subscribes, share, and hit the notification bell icon, especially for our new viewers or our returning viewers who are yet to subscribe. so that each time we release new health tips or videos, you should be notified as well. Lastly, intradermal skin testing, the Montenegro or Leishmanin test, is a delayed type hypersensitivity reaction similar to the Mantoux tuberculin skin test. The test is not widely available and may be useful for epidemiological surveys to identify high-risk populations. Positive test results may be seen in patients with ML and CL, however. Those with active VL and diffuse CL typically test negative. Treatment. Similar to diagnosis, treatment of leishmaniasis can be quite challenging. Overall, leishmaniasis treatment should be tailored individually to the patient, the type of leishmaniasis, and the parasite subspecies. PCR testing for species identification is particularly helpful in guiding therapy for patients with cutaneous disease who may be at risk of ML. Cutaneous leishmaniasis treatment is based on the clinical presentation, host, and species type. In an immunocompetent individual with no evidence of mucosal disease, CL caused by L. mexicana and L. major does not require treatment, as it usually spontaneously resolves. Unlike CL, mucosal leishmaniasis does not spontaneously resolve and may lead to progressive destruction, disfigurement, and even death due to aspiration pneumonia or respiratory obstruction. The IDSA recommends inpatient monitoring and prophylactic steroids in patients at risk for respiratory obstruction, which can be worsened by the initiation of anti-leishmaniasis therapy. As visceral leishmaniasis is the most serious manifestation of leishmaniasis, any person with signs and symptoms and a confirmed diagnosis of VL warrants early systemic therapy. Pentavalent antimonials were previously considered the standard of care, but there is a concern for developing resistance among Leishmania species. Patients who receive successful treatment for all clinical forms of leishmaniasis should be monitored for relapse. In patients who have a recurrence, repeat treatment is advised, usually with liposomal amphotericin B, and longer duration treatment regimens should be considered. Drug resistance testing is, unfortunately, not commercially available, and repeat biopsies and serological testing are generally not recommended. Conclusions. Leishmaniasis is a complex clinical syndrome that is difficult to diagnose and treat. Advances in vaccine development, diagnosis, reporting, and treatment could prevent substantial morbidity and mortality from this disease.